Dear audience, my name is Cozma Tudor-Cristian, and I'm grateful to be here in front of you to present the progress attained over the first 6 months of my PhD. I will make the best efforts not to bore you down for the next few minutes with my part thesis titled New Insights Upon Adverse Events of Statin Treatment. I was lucky enough to be selected to be part of this bilateral PhD program, which, as the name suggests, takes place both here in Budapest and also back home in Iași at the University of Medicine and Pharmacy Grigore Tepopa. Peter Ferdinand, Renata Pape, and Ionela Lăcremera Șerban are my distinguished mentors, and Amir Makoli is my trusty SMS. I came here to Budapest with a very clear vision. That is to provide prolonged, healthy, and independent lives for the elderly. However, to achieve that, my team and I have to fulfill a pretty difficult mission. That is, to disentangle the ways common medication impact on the musculoskeletal system. These are the two long-term projects that I plan to accomplish till the end of this year. They were started at the last part of the previous year, and they will both be finished using the systematic review and meta-analysis methodology. Let me introduce you the first one of my projects, titled Investigating the Effects of Statins on Development of Sarcopenia. My two co-investigators which take part in shaping this idea to life are Bertalan Tordai and Victoria Barna. A bit of background. Sarcopenia is no more just an obsolete, outdated term concerning every single description of elderly population. No, in fact, the most new guidelines define sarcopenia based on 3 pillars, or 3 laws if you would allow for. The three laws are as follows: low muscle strength, low muscle quantity, and low physical performance. But then what's the link between sarcopenia and statins? Well, back in 2018, following cholesterol guidelines would lead to more than 20% of the population to be recommended for treatment with statins. And you can imagine that this problem has been since compounded by the ever-aging trend in the population. Also, there is a plethora of studies concerning the impact upon musculoskeletal pain treatment with statins sometimes elicit. Therefore, it is our responsibility to understand whether treatment with statins, or rather said, adverse statin treatment, is limited to just a negative symptomatology, or it's actually translated in a low physical performance. We employed the PICO framework, where the only filter for the population is adult age. The only difference between the intervention and comparator arm of an eligible study is statin treatment, and all outcomes of interest are biomarkers or physical measurable parameters revolving around sarcopenia as a spectrum. Our hypothesis is that treatment with statins is safe regarding the risk for sarcopenia in adult patients, and the clinical implication of our study translates into a better tailored approach from the practitioners towards the population regarding initiation, continuation, or discontinuation of statin treatment. Here's our search key. It was employed using 2 domains, 2 limiting domains. The intervention concerning every single statin is still in use, and the outcomes again revolve around any measurable and included in current sarcopenia guidelines. This is the flowchart selection. We started with more than 17,000 hits before the duplicate removal. Careful refinement led to 69 eligible full text in the initial phase. However, as you can see in the right part, we find ourselves in the later part of chaser selection. Again, this flowchart shows we are still ongoing in the chaser selection. We are approximately at 50%, give or take each member's percentages. Let's now move on to the second project, titled Assessment of the Efficacy and Safety of New Antidiabetic Drugs on Improvement of Inflammatory Profile. This again will be done using the systematic review and meta-analysis methodology. Bit of a background. Back in 2021, more than 500 million people were affected by diabetes. And the most pessimistic projections expect this figure to rise up to 1.3 billion people by 2050. What's more important is that the bulk of it is represented by type 2 diabetes mellitus and patients in the age range 75 to 79. At such an advanced age, it is obvious that cardiovascular protection has to be focused upon mitigating the inflammatory process. What about inflammation? Well, one of the main culprits in heart failure and blood vessel rigidity obviously is fibrosis, a consequence of inflammation. Fibrosis can indeed be tapered, not stopped, but at least tapered, by the anti-inflammatory actions the newer antidiabetics drugs prove. Indeed, GLP-1 agonists act at several key sites inside the cell and not only intracellular, which all those key sites converge into an inhibition of nuclear translocation of NF-κB, leading, as you see on the slide, to a lower activity of CRP and TNF-alpha, more importantly, consistent in clinical trials. Not only GLP-1 receptor agonists do this, but also SGLT2s. So undoubtedly, inflammation is a key process that has to be stopped if you want to improve the health of elderly population. And our mission becomes to find out which drug, which class of drugs, and maybe which exact drug exhibits this action the best, turning, therefore, into a better care standard for the patient. Our clinical question is, again, using a PICO framework. The population of interest is adult patients with type 2 diabetes mellitus. Intervention is any anti-diabetic drug in the GLP-1 agonist and SGLT2 inhibitor classes, the newer ones, compared to placebo. And outcomes of interest revolve around inflammatory markers, major adverse cardiovascular events, 3 points or 4 points, depending on what we find, quality of life improvement, and last but not least, traditional and non-traditional cardiovascular risk factors. Here's a summary of our key articles. There's a plethora of studies concerning GLP-1 receptor agonists or SGLT2 inhibitors versus placebo. However, the same cannot be said about what you see in the left column of the slide, comparing in the same study on 2 different arms, GLP-1 receptor agonists versus SGLT2 inhibitors. These are the 4 studies that came up so far through our search. However, they come with a slight disadvantage. They are an add-on type of treatment, thing which has to be carefully analyzed comparing to the other studies included here. As a summary, these are the 2 projects I have started. I plan to finish them, the first one by September 2025, the next one by the next year. And I'd like to end my presentation with a quote: "The road to success is always under construction." This is a quote by a famous actress I actually found out about this week. Thank you so much.
As far as I know, regarding to your second topic, there are already a bunch of meta-analysis on that field. So what makes you think that your meta-analysis is needed and unique in that case?
Thank you for your question. This was actually a question that popped up during our group meetings. Most meta-analysis published, I think all of them that have been recently published, do not include all drugs from all these categories. Some of them compare, for example, this is the one I remember best, semaglutide versus all SGLT2 inhibitors. Or they compare SGLT2 inhibitors inside the class, or GLP-1 receptor agonists inside the class. Or they limit to a certain year of publication. For example, one of the best ones published actually in December limits to articles published after 2013. So I think by including and carefully grouping every single article we can find, and maybe comparing the effects, even though they are not in the same subgroup, we can provide some more information.
And I'm really interested in your first project, and I was thinking whether you were about to have other outcomes as well, because you chose sarcopenia, but maybe you could have secondary outcomes such as harder ones like MACE. because if you think about statins, you can better estimate the risk benefit balance maybe, or if one has to choose between a longer life with some kind of sarcopenia or a shorter life without sarcopenia, maybe I would choose A.
I understand.
If you understand what I want to mean.
I understand your question. Unfortunately, I have to be pretty honest, we didn't consider any other outcomes aside from the sarcopenia spectrum because we were interested to see whether statin treatment leads to more than musculoskeletal pain, because this is everywhere in literature. We wanted to see whether there is actually a lowering in strength. However, I think your suggestion is a very good one to include MACE 3 points, 4 points, and to compare the benefit of lowering MACE versus sarcopenia. Yeah, I understand.
Thank you very much for your presentation. It was like listening to a story. So regarding your first project, what are the biomarkers and the physical traits analyzed in the studies?
Yes, thank you for the question. Indeed, we based our outcomes only upon ESPEN and ESPGAN guidelines in order to be sure that our biomarkers and our parameters do not really interfere with frailty, because the limit between frailty and sarcopenia is a very narrow one, and we want us to be focused on sarcopenia. So yeah, those two guidelines.
Thank you very much.
Thank you. Next one, please.
Hello, Tudor. That was cool, thanks. As you mentioned, I'm one of your selection pairs, so I have had the opportunities to swipe through a couple of your articles, and there is a problem what we haven't discussed yet. The population and the statins, most of your population is already on a bunch of medication and are restricted on diet or sport or physical activity or both of them. So they will be. So you will have a baseline of some level of sarcopenia. So how would you handle that?
I understand the question. Thank you so much. So first of all, the outcomes will be assessed as a mean difference or standardized mean difference. We still have to see after the final data extraction. So using a mean difference does not really need to set a baseline measure for strength. We just assess what the statin does as an intervention. However, you mentioned that there are certain populations which are predisposed to sarcopenia. Indeed, we included every single type of population, that is chronic kidney disease, HIV, people living with AIDS, however. And yeah, we will subgroup upon those because maybe in those populations the certain diet or the certain physical limitations will not allow for the statins to get the same effects. But to respond to your question, we do not really have a baseline data. We just assess mean difference.